Up next is the QEH Pulse Radio Show, brought to you with the kind compliments of MedSafe Medical Supply.
Welcome to another edition of the Pulse Radio Show. It's always a pleasure to be with you on a Monday morning at 11 a.m. where you get a chance to hear all about what is happening at our hospital, your hospital, the Queen Elizabeth Hospital. Now, we have been spending the past few weeks sharing a lot of information with you. You would have known from the beginning about some new developments in accident and emergency and across the hospital in general. And we've been focusing on, improving efficiency across the board, but also helping you understand how best to use your hospital. This month, I find that because there are so many different conditions that we look at on a daily, weekly, monthly, and annual basis, some conditions now share months, and in terms of raising awareness as far as that is concerned. So this month is Colon Cancer Awareness Month. This month we are also focusing on the kidneys as well. And funny enough, I think the color for both of them is blue. For kidneys is green. Okay. So green and blue, they're too far apart. So I got a little whisper and a little reminder there about the color. I should know my primary colors, but especially as far as these conditions are concerned. So you'll be hearing us raising that awareness through the show about a number of these conditions which our medical teams are really dealing with on a daily basis. But it's all about helping to promote a proactive approach about early detection and really allowing our teams to getting there early in the event that you have one of the signs or the symptoms of these conditions, and do what they have to do so that they can save your life. And speaking about saving lives, I have two ladies here, and I'll let both of them introduce themselves here for you, because they are a part of our transplant team, our kidney transplant team at the Queen Elizabeth Hospital. So yes, we're going to be talking a bit about dialysis today, but the focus is on transplant and a new lease on life. So first, let's start with the lady to the left. Good morning.
Good morning, Shane. Thank you for inviting me on the show. I'm Margaret O'Shea. I'm a lecturer in surgery with the University of the West Indies, and I'm also a renal transplant surgeon at the Queen Elizabeth Hospital, part of the transplant team.
And last but not least, another beautiful lady in here with me, and we are celebrating the ladies especially this week as we go into International Women's Day on Friday. There are a lot of awesome women doing great work across the board, but at the QEH, they are the dominant force there. Our nursing team speaks for itself, and she is also one of them. So I'll give you that chance to introduce yourself as well.
Hi, good morning, everyone. Thanks for having me here. My name is Ruth Shorey. I'm a registered nurse, and I'm also the hospital's renal transplant coordinator.
Right, so we have our registered nurse, Nurse Shorey here, our renal transplant coordinator, and Dr. Margaret O'Shea, who leads the transplant team. And this team has been doing a lot of work. It's a small team, but they do big work at our hospital, helping to save lives and really helping to, we always talk about dialysis. I know dialysis should be a common term here in Barbados. There are a number of patients on dialysis, and we're going to go into some of the numbers as well. But Dr. Margaret O'Shea, I'll let you lead off the conversation this morning after I give our audience the numbers to call: 4341007, and you can also call 4341070. You can send us a WhatsApp as well at 4341007. Dr. O'Shea, great to have you here to talk about some of the work that you do. So for our listeners out there, explain to them what is a renal transplant surgeon?
Okay, so basically my role is, well, let's just go back to what the surgery involves. Generally, when patients are at a point of end-stage renal disease, so this is where now the kidneys are no longer working, they have the options of dialysis, either hemodialysis, which uses the blood to cleanse, or peritoneal dialysis, which uses the fluid in the abdomen to cleanse the blood, or they can have a renal transplant. So basically you will have a new kidney put into your body that will take over the role of the kidneys that are not working. And my role is to actually do that operation, to put the kidney in and also take the kidney out in the case of the living donor. And well, we don't have the ability to do that here, but where I trained, you can also remove the kidney from a deceased donor. So, but that is the final part of an extensive workup for 2 patients in the living donor program that involves a lot of teams and specialist review. And our team is 2 surgeons, myself and Dr. Natasha Paquette is the second surgeon. We have 3 nephrologists, Dr. Lisa Bell, Dr. Narissa Jarawan, and Dr. Daniel Dotting, and of course our coordinator who keeps us all together, Mrs. Ruth Shorey. But that is Miss Shorey. That is a team, but then the team has many tentacles involving anesthesiology, psychology. Of course, there's a lot of lab work, investigations that have to be done. Nursing is a huge part, both in the operation itself and also post-op. And also we have an ethics committee that's chaired by the chair of the Hope Foundation, so Shirley Ware, and just to make sure our pairs are vetted and there is no, they're doing the surgery of their free will and there's no coercion, because of course we know, particularly in transplant, sometimes you have some illegal activities and people paying for organs, which is definitely illegal. So we have a ethics committee that vets our pairs before. So a lot goes into the workup of the operation, but I definitely come in at that part where we actually do the operation.
Nurse Shorey, speak about coordinating the operations that Dr. O'Shea and her team do throughout the year. I know we've had one earlier this year, and we'll get into that very shortly. Another 2 earlier this year, very successful as well, and things are going well as far as those patients are concerned. So talk about the coordination effort.
Right, so as the transplant coordinator, most of the time I'm the initial contact of persons trying exploring this treatment option. I see them, I do the interviews. At that interview, I will give them the information that they need, tell them about the surgery, about the tests, ask any questions that they might have. I also arrange blood tests, other investigations. So it's coordinating and facilitating. I'm the kind of like the linchpin around which everything moves. Mm-hmm. I keep the doctors kind of like let them know that we have these persons who are interested. Tell them know that surgical reviews or medical reviews are due. So then that's where they will come in and they will see the patient, the clients. They will then decide if we're going to go further. We're going to order other investigations. So it's like keeping everything on track. I also work with other members of staff. So like if we know we have a date set, I will then work with the theater nurses, the theater manager. I will work with the anesthetic aides, so that he can prepare the things that he would need. I would work with the nurses in the surgical intensive care unit, let them know that these are things that they're going to need, and I also work with the nurses on Ward A5. So as I say, it's coordinating and facilitating. Part of my job is in theater as well. So anecdotally, people would say that the kidney is my responsibility, but it's just that I'm there I'm the patient's advocate, right? So I'm there just to make sure that all goes well, just circulating. There are certain times that we need to record, so I like to know those things, because at the end of the day, that she's going to ask, what is this and what is that? So I need to give her the information.
Right.
I also, there at the end, immediate post-op, facilitating blood tests and stuff like that, and investigations. But a big thing is the long-term care. That's where it really comes into play, the rehabilitation of these patients, long-term care, getting them back, because they have no life on dialysis. It's very restrictive. So it's going to be a whole different way of thinking and living now. You can't drink fluids. You're not restricted anymore. You can travel. You can do this. You can do that. But you also need to do things in special consideration. So I'm there just to guide them and how to get the life back on track.
And that's why I themed this show A New Lease on Life. Yes, it's not your regular, you'll be on a different diet. You have to change your lifestyle and change your habits. But the options going this direction in terms of getting the transplant are a lot better than the other option, which I will let you, Dr. O'Shea, speak about, our dialysis situation here in Barbados, and the growing number of people that are coming on dialysis, and moving more people in this direction of getting transplants, kidney transplants, would help to wean some of those individuals off of the dialysis program. And it's a better way to live, a healthier way to live after you get the transplant. Talk about the dialysis situation in Barbados if you can.
Well, yes, we do have, because of the increase in the big buzzword NCDs, the non-communicable diseases, so the increase in hypertension, increase in diabetes, all stemming from the increase in obesity. The numbers of patients ending up with renal disease is going up and up. And then hence the numbers ending up with end-stage renal disease is increasing year on year. So we're now about 400 patients that require this dialysis, in which form, either the hemo, which is predominantly what we're doing, and also we have peritoneal dialysis. I mean, I'm not a nephrologist. My role usually is to provide access for the dialysis, which may be a fistula or a special catheter that goes inside the abdomen. But yes, it can be very limiting, as Ruth said. With the hemo, you're expected to come to the unit, 3 times a week, spend about 4 hours. The patients will tell you it's very tiring after, and of course, restrictive diet. And with the peritoneal, you can do it at home, but then again, you have to put yourself on a machine every night. So it's a challenging life. I think a lot of the patients, they manage, and of course, you make adjustments to your lifestyle. But yes, to then be able to free yourself from dialysis, it's a huge change, and many studies have shown patients live longer and a better quality and quantity of life after receiving a new kidney. Of course, I think the big challenge is you need somebody to give you the kidney, and sometimes you have patients, they don't want to ask, nobody's offering. So, that's what they tell you. It's a big ask, but I would emphasize that the donation process is safe for the donor, and of course, after fully investigating the donor to make sure that they're a healthy person, is only then that we would suggest that they go forward for the surgery. Of course, in other countries where they have the legislation, there's something called deceased donation. Patients who have had a sudden tragedy and they're declared brain dead, which is in fact dead because there's no chance of recovery. Those patients can also be donors, and it's obviously that case a less stressful situation because there's no worry in terms of something happening to the donor, they're already dead. So that has an option. I'm sure everybody's reading and hearing all about the different things happening with using pig kidneys. So because the donor pool is so difficult, and this is internationally, the need for organs far outstrips the donors. So there's a lot of research going into trying to find other options beside living donation, beside even using humans, to try and meet this need, because the patients coming on to dialysis or liver failure or having lung problems, heart issues, that end up needing new organs, that number is a lot higher than the ability to replace those organs, and this is across the world.
Okay, so we are going to come back and look a bit at this situation a bit more, and how Dr. O'Shea and our registered nurse Ruth Shorey and the team can help to address that, of course, with some help in terms of changing the culture as far as donations are concerned here in Barbados. That is what we are pushing for, and that's why we're really having this conversation here today on Q100.7 FM on the Pulse Radio Show. We'll take a quick commercial break. Of course, the Pulse Radio Show is being brought to you compliments MedSafe Medical Supplies on Gemets Lane.
For all medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemets Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Back with you here on the Pulse Radio Show. I have registered nurse Ruth Shorey with me. She's the coordinator of the transplant program at the Queen Elizabeth Hospital, and also Dr. Margaret O'Shea, our lead transplant surgeon, really helping to save lives and help people to have a healthier option coming off of dialysis. Before we went to break, we were talking about the program, but let's welcome in our first caller for the morning. Good morning, caller. Welcome to the Pulse Radio Show. How can we help?
Good morning. Peace be unto each and every one.
Good morning.
Thank you.
Blessings to your God-gifted guest with the talent to prolong lives. Shane, I'm very interested program this morning as always, but I'm calling. I don't know if it is done from last week. Next to the appointment section, where the entrance, by the doorway, you make your appointments. The numbering system is not in service.
Where is this again?
The appointment where you go to make your appointments.
Mm-hmm.
In the entrance where the security guards are.
Right.
When you're entering, right.
Mm-hmm.
They are on your left. And it was difficult because some of the persons who came out then calling they're calling the other number, like the number after theirs, and it was difficult. So persons didn't know who next or whatever. So I'm not criticizing, but I'm just, letting you know that the numbering system, and don't know if it's finished with or if something wants servicing. But you need something there so that persons would know. Because they have to be asking, and some people when they come out, they just go there, they're not calling the numbers, so it's difficult.
Okay, something that we can look at. I will check with the team there to find out what exactly is happening as far as that numbering system is concerned, because I know that they would normally call the number. Right, it's not. Yeah. Not calling the number, so you have to be asking persons when they come out. Some persons will come out and say, well, not. Some persons come out and they just, go there. So it's difficult. Thanks. I know you always identify these things that we can look at the hospital, and I appreciate that. Shane, the radios, they ask you to call the programs and voice your opinion. And some people, sometimes the staff, and maybe
listeners don't want to hear people, but you know, if there's something that will affect others, because it's difficult. You got to be asking, ma'am, what is your number? Sir, what is your number? But what number you have?
Mm-hmm.
So if the system is working, you know, you'll be able, the number will call out so you will know which is your number. But when you call people saying that you're knowing the radio and you're doing this and you're doing that, I ain't criticizing the hospital, but if things need to be done, I will speak.
Yeah,
thank you very much.
We
God bless
appreciate
you all.
that.
God bless Barbados.
Don't go yet, because I just want you to give your contact details to the producer so that we can get exactly from you, so we can understand what exactly is the issue. I know I heard you just now, but I just want a few more details so that we can see how best we can correct that problem. But thanks again for calling, as always.
Thank you.
Yes, appreciate that. Yeah, we'll try to get it right, and we need that feedback so that we can ensure that we get things right at the hospital. We have Dr. Greenidge on the line, our Chief Operations Officer, just joining the program to chime in, because she was a big part of the initial thrust as we started to really promote what we are doing as far as transplant surgeries are concerned. We want to do more, but a framework needs to be put in place, and it's something that is being worked on. Dr. Greenidge, pleasant good morning to you.
Good morning. Good morning to you, Shane and Dr. O'Shea.
Yes.
Good morning.
And our registered nurse, we know how you feel about your nurses. Our registered nurse.
Oh, absolutely.
Ruth
How
Shorey
could I forget?
is here as well.
Good morning.
Really speaking about the need to really push the idea of a culture of donation and transplant surgery in Barbados. Of course, Dr. O'Shea focuses on the renal side of things, but you would have seen our initial push, one of the initial pushes since I came in to office, to really get the conversation going. We know things are being done on the back end to try to get the legislation so that Dr. O'Shea can do more with her team. But maybe you can talk to us about what you would like to see as far as the vision is concerned for transplant surgery in general.
I think that there are two factors related to this. And I still think that for the most part, we have to do better in educating our public about the benefits of transplants. And most importantly, when it comes to kidney transplant, that, you know, if you're relatively healthy as part of a donor, you can live the rest of your life pretty routinely, meaning that one kidney can suffice to take care of the body. And I think when we narrow that communication gap and that knowledge gap, that I think the country will be much more on alert and more aware of the benefits. Secondly, if we look at our growing numbers of public patients who are now seeking dialysis as treatment, we can, with proper donation and matches and even a bank of available folks who can donate kidneys, will be reduced as well. And thirdly, there's a segment of the population who also receive a different type of dialysis called peritoneal dialysis that's done through exchange of a certain dialysate solution. So there is a lot to learn, and I really want the transplant team is doing an outstanding job, wonderful job in terms of our small island Barbados, but we can do a lot more. And I think when we make the public aware that safe donations can happen, if you have a loved one who is currently receiving dialysis, why not come in and get a sample to see whether or not, give a sample whether or not you can be a fitted donor for a family member, for good friends. And it means that we have to think out of the box and understand what a safe donation can be, but most importantly, thinking about the recipient's quality of life changes immediately. Yes, there are long-term medications that someone would have to be, but what a difference in living a pretty normal life as a functioning kidney, as opposed to having to come in 2-3 times a week to receive hemodialysis. So, Shane, I'm very strong on educating the public, but something like this is very sensitive. And, there's segment of population. There are many people who feel that I want to go back to my Lord, how he sent me, all in one piece. But when we think of transplant, not only kidney, but cornea transplant, a whole lot of different possibilities, we really have to be much more aware and be comfortable in the knowledge that, yes, I can be a safe donor as well I can be a safe recipient.
Indeed, Dr. O'Shea. What can we do to really encourage a greater donor culture? I know you would have seen in other parts of the world what is being done to promote it in other jurisdictions. What does Barbados need to do? What do we need to do on the ground at the QEH to push this culture of helping people to understand, giving to your loved ones, and going even a step further, as Dr. Greenidge would have mentioned, having a bank for a donor bank.
Well, with thank you, Shane. With kidneys, we don't really have a bank. You have to take it, either from the living or dead person right away. You can do banking with like corneas and other types of tissue.
Right.
Like bone and skin. You can do banking mostly with tissue donation. We do have a corneal transplant program at the hospital, QH, as well. I don't know if everybody knows that. But those corneas have to be bought and brought in from overseas because they have banks in these other countries. But where I have seen donation, the investment has to be there in terms of really marketing and having that public awareness. You would see in countries like Spain, they invest heavily in a marketing department promoting the good things about transplant, and that's a whole department. That's all they do. It's always on the radio, it's in the schools. Whenever they have, a successful outcome, it's promoted. So I think from young, it's there in the culture, it's there in the population. And having constant PR meetings. We had a very good session last year. We invited families of patients who are on dialysis to come. A lot of Q&A. People have questions, that they want answers to. So I think information, as Dr. Greenidge said, needs to be more information to be given, more outreach in that area. So I think that there is an investment that needs to be put into that aspect. The same way when the government rolls out something new, they have it on the radio. People know what's happening with seatbelt laws, what's happening with, well, hopefully forget the drink driving at one point, going on with the mosquitoes. I hear it on the radio myself. So we can't, the benefit of the media is so important in terms of rolling out good things and what we need to do for the community. So we would have to invest in that because using the media costs money. So I think that's what we need to recognize, that we have to get out there and get to the population, get to where the people are, churches, obviously sometimes the rum shops. And we're the community.
Okay.
We're the community. Exactly. Where the community is and hear their questions and answer them. But we are busy professionals because we are actually doing the transplant. So but we make the time. I'm here today. Miss Shori is here today. So we have to make the time to get out there and hear these questions and give people their answers so that we can improve more donors. So that's what we want. We want more donors.
Yeah, the other thing, Shane, the question that you posed, what comes to my mind is something that's very common, and I'm not sure if it's all the states, but certainly in New York State, for example, on your driver's license, on the back of it, you can indicate whether you want any type of donation. If you should be in a fatal accident and or otherwise, it tells you right on your driver's license that, yes, I'm a donor, and whatever organs can be harvested is done, and that's the desire of the individual. But yes, we have the cultural, we have to understand the culture where there are people who believe that they want their body to go back intact if they should pass, tragically or otherwise. But then there's some who, I think with proper education and knowledge, can say, yes, if I should meet tragedy. Recently, we have a lot of young folks, Shane, in various ways of losing young lives, whose probably was very, very healthy prior to meeting a tragic death, of which organs can be harvested and other means of saving whether it's the site or any other parts for another human being. So these are things that we need to talk about and be comfortable about. And I think that's one thing. I'm not sure if it's in the legislation where someone of sound mind can indicate that's their desire, they wish to donate organs, but certainly I hope it is.
Yeah, Ministry of Health and Wellness is actively looking at finalizing that legislation so that Dr. O'Shea and Nurse Shuri can take our program at the hospital to the next level. These things are a work in progress, but of course, as these things happen, we will update you right here on the Pulse Radio Show. Nurse Shuri, recently we had some success in terms of a viable donor, viable patient, and a happy outcome. And I saw a pretty picture of you, yes, I saw a picture of you. A nice picture was sent to me, sent to my phone, with the patient standing next to that picture. Talk a bit about that experience, taking, as you said, you coordinate things, taking that patient from what they would have been doing before on the dialysis program to now that new lease on life where they have that kidney and they're ready to live their life again.
All right. Each pair. Oh, that one.
Yes, that picture.
Each pair, I would say, each journey is different.
Yeah.
They will come to you. They're a bit, they're not certain about should I really be doing this. Some the recipients are shy. They're not sure if they want to do this, but the donors are like, yes, I want to do this. You're wondering, like, easy. You can't be forcing. You can't. This is like forcing yourself, forcing this person to take this kidney from you.
Yeah.
It's a lot of patience because you at each step you're explaining to them what is happening, what's going to be happening, the possible outcomes. It could be a good outcome and we go further, or it could be an outcome you don't want to hear and we have to stop, or we have to pause. We set a timeline of 18 months from the time they come through the door saying this is what we want to do till we get them to the surgery. Sometimes it can be less, or it can take a little longer. I've had persons take about 2 years to get there. The journey to transplantation can got a lot of pit stops. It don't always be straightforward.
Right.
As I said, I just try to help them navigate this whole thing, explain what happens, what's going to happen. Again, I say facilitating tests and stuff like that. Then when the date is set, things change a little bit because they know okay, it's a reality now. They get a bit anxious, so you're trying to help alleviate some of that anxiety. If I try to arrange a little chat, a little meetup when they come to the clinic,
right?
If there's another person that went through the process and they come to the clinic, I let them have a little talk.
So like a testimonial of sorts.
Yes, let them know that somebody went through this, is just like you're going through it, and they're here, they're good. You can like proof of life. I do the same thing for the donors as well. Some donors, I find, yes, they want to do it, but sometimes you still have to make sure that your donors are still they're still in it, because donors are free to change their mind at any point in time. So we just want to make sure that we still have them in this.
I could understand it because you're giving up a part of you, and generally, as you said, Dr. O'Shea, the information, while we do it from time to time, the information is not always front facing. You don't have it. You have it at your fingertips, but you don't. It's nothing that is a daily conversation. It's now something that we need to bring to the breakfast table. But before we get back into the conversation, because I really want you to talk about some of these successes you had already this year, Dr. Greenidge, in terms of what you would like to see our hospital going to, where we need to take it, what is your vision? What would you like to see as far as our transplant program is concerned? Dr. Greenidge?
Hello?
Yes.
Are you hearing me?
Yeah, I'm hearing you now. No, I was just asking you, what would you like to see as far as our transplant program is concerned?
Shane, just repeat. I had a little difficulty hearing.
Yeah, that's no problem. In terms of taking the transplant program to the next level, what would you like to see?
Well, I would like to see the most important thing is for us to keep our registry up to date in terms of people who have the potential to be recipients. Secondly, we need more intimate conversations from our current patient population who are on dialysis, more intimate conversations with relatives if folks have not yet tested to see if they can be a potential donor, more of that tight coordination. And also just general infusion of public information about the wonderful program at the hospital, but also folks decreasing that knowledge gap about the fare, and I think that it is a fare when it comes to donating, that the fare of having one kidney as a result of a donation may mean a compromise and or difference in terms of quality of life. It is a difference in quality of life for the recipient, but the donor needs to be assured that he or she can live comfortably with one kidney. I think that is the biggest gap that exists. Certainly the reliability of our program has proven itself. The transplant team, the kidney transplant team, has done outstanding jobs, and there are many patients in the communities are living very well from that donation of a kidney. Maybe we need a little bit more of their voices as well, so that, you know, as a lived experience in receiving a kidney can be shared. So the patient's voice, I think, is something that we can literally harvest more, and let them talk to the general Barbadian public about the difference in and what receiving the kidney has meant for their quality of life.
Yeah, more testimonials to come for sure.
Yes, that's the word.
Yeah,
indeed.
And I know Dr. Shea will help to provide those successful patients, the donors as well, so that they can share their story, possibly right here on the Pulse Radio Show in the weeks to come. Of course, as always, Dr. Greenidge, thanks for your input. Appreciate you.
And thank the transplant team.
For sure.
Ms. Shuri and and Dr. O'Shea. Thank you guys.
Thank you.
Yes. Okay. And I know there's a long laundry list. Well, not long. Another list that Dr. O'Shea would have mentioned in terms of those other doctors and nurses who work with the team. We salute the work that you do at the Queen Elizabeth Hospital. You're listening to the Pulse Radio Show, a production of the Queen Elizabeth Hospital. We'll take a quick break, but remember those numbers to call, 434-1007 or 434-1070 if you have any questions about renal transplantation and the work being done at the QEH.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
With you on the Pulse Radio Show, speaking about renal transplant, kidney transplants, and what the team at the QH has been doing to really not only promote it but to encourage that donor culture here in Barbados. It's in the embryonic stages, but we really want to grow it so that we can get more people off dialysis. I'm here with Dr. O'Shea and registered nurse Shori, two members of our transplant team who recently, this year, we did 2 transplant surgeries. Talk a bit about that, Dr. O'Shea. I know you're aiming for more throughout the year, and we are hoping to increase capacity in that regard. You've set a target for 20. We're going to get back to that. Let's talk about the 2 that were done early this year.
Yes, early this year we did a pair, brother and sister, and mother and son. The donors were in hospital average of 2 days, and they left quite healthy. I do agree, just to segue, that we could do more with letting donors promote our donors, so that we can encourage other people, because doctors can say a lot, but it really helps when it comes to the patients who've been through it. There's nothing like having that lived experience. So, and they're doing well, the donors. One of the donors, it was important for us to ensure her employer that we had accreditation, gold accreditation for our program, as is the hospital. And mother and son also doing quite well, and mother discharged within 2 days.
Wow.
Yeah. The recipients were in hospital an average of 10 days. Obviously that immediate period, getting used to taking a lot of medications, particularly to prevent the rejection of the kidney. Even though we do careful cross-matching before, starting with blood group, to make sure that there's no rejection. And then we do even further specialized tests that have to go overseas. We still have then to make sure the patients take their medication to prevent the kidney from being rejected, and also special medications to prevent infections. So it's a change in life, and that takes a little time. So we hold on to them a bit longer as the kidney settles in. And then, of course, you go from making sometimes no urine to making 5-10 liters in the initial period. And then it slows down over time. So all that time we are monitoring the patients before letting them go, make sure he's there, going through with them every day what they need to do in terms of their medications. I would like to highlight that our new sustainable program, which we started in 2015, we are being supported by a UK team, a charity, Transplant charity, and they just give some oversight to make sure, when you're not doing them as regularly as we would like to. Of course, every pair we have to make sure that we're maintaining international standards, which we do. And we partner with Transplant charity, who have been tremendously supportive in this recent establishment of our sustainable program. And of course, one of our big sponsors, Republic Bank. We did transplants here from as early as 1987, but things sort of were sporadic and then kind of fell off. But this new push was since 2015 with the sustainable program, which took a bit of a hit with COVID, but we're back on track, and we want to increase our numbers year on year to not only improve the quality of life for our patients, but it's more cost effective. Once you get to a point after the surgery and you're taking medications, it's so much cheaper to maintain patients who've had end-stage renal disease. So we show that it's better quality of life, longer life, and also more cost effective. So it's a win-win on many fronts, this renal transplantation for these patients.
Yeah, speaking about win-win, Nurse Shori, speak about having that conversation with the patient after the surgery now. They have a new way they have to adopt a new way of thinking as far as their taking of medication, and also their lifestyle generally, probably their diet and exercise.
Right. So initially after the surgery, the main risk for them will be infection. So I usually tell them, if you don't have to be out, stay home. But if you have to be out, you wear your mask, because the doses for those immunosuppressive medication, they are high, so they are really at high risk for especially viral infections like flu and things like that. Also, they have to get to know the medication. I'm gonna be honest. When you're living with a chronic disease and you have to take all this medication, there are some days when you will cheat. There are some days when you are not going to take your medication. But with these drugs, that's not part of the discussion. If you miss your doses, the body's immune system when it's doing its checks and balances, it's going to realize that the blinkers are off. It's going to start to realize this kidney is not yours, and then it's going to try to destroy it. So we try to get them to understand you can't miss a dose. You need to take your medication. The dose according to how you're supposed to take it, the correct dose and the times, they're like 12 hours apart, morning and night. Also, another thing with them is food handling, how they prepare the meals. Before, sometimes we take chances in the kitchen and it doesn't do us anything.
Right.
But now, when you're on this medication, your gut immunity is not at its best, and you can pick up a food. You can easily get food poisoning.
Whoa.
And so we tell them, if you don't have, try not to dine out. If you prepare your meals at home, but if you do dine out, be very cautious about what you eat. So there's some things that they can't eat, especially yogurts and shellfish.
Oh.
Because especially shellfish, they're high risk for food poisoning.
So people may say, and we can talk about this after we come back from the commercial break, with that restricted diet, which should I really go through this? Should I just not stay on dialysis and not have to go through that?
Yeah.
People will have those questions. Because as you said, in some cases it can be a long process. But let's address this after this commercial break.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
You're here with us on the Pulse Radio Show with Dr. O'Shea and registered nurse Shori, speaking about the successes of the renal transplant program, kidney transplants, giving a whole set of people a new lease on life. But they need to do their part as well. And one of the focuses of this Pulse Radio Show, this third season, has been promoting a more health-centered approach to life, being more proactive in terms of taking care of your health. And I think that is the direction you were going there with Nurse Shori, in terms of after the transplant, helping patients to understand how they need to take care of themselves so that this new kidney, giving them what is a new lease on life, can really be a part of how they manage their diet, their lifestyle, a healthier lifestyle going forward.
Right. So remember, before the transplant, they would have been on a renal diet. That diet, especially if you're on hemodialysis, is very restrictive. It's fluid restrictions. You can't eat this. You can't eat that. But once you have your transplant, apart from, as I say, with the initial stage where you have to be very careful because you're taking high doses of medication and it's affecting your immune system and you're at risk for infection and stuff like that. Once your doses kind of like settle down, because each dose is tailored to the individual patient. So once those doses are a bit lower than when they started out, they will, and the lab values come back down to a range where we are happy. We will find that the diet, that this restricted diet that they were on, it's more liberal. They're almost like a normal diet. They just have to make sure they drink the fluids. They can have watermelon. They can have pineapple. They can have peas. They can have, except for the shellfish and yogurt, in the initial stages. But they can eat whatever they want to eat. It's just the only considerations that we were going to have to look at is if you're a diabetic, obviously you have to watch your calories, watch your carbs. If you're hypertensive, obviously it's a lower salt diet. But the diet for a person after transplant is almost like yours and mine.
Okay, yeah. So that means instead of spending so much time in the dialysis unit in AKU, you can do other things with your
Yes,
life.
you can travel, but not in the first year though. We don't advise you to travel.
Okay.
We see when you're on dialysis, hemodialysis, when you're traveling, there are a lot of factors you have to take in consideration. You have to find, especially going to another country, you have to identify a center that's going to be near to where you're living, that is going to be open when you're going to be there, that can take you when you're going to be there. And you also have to have the funds to pay for it. So some of your spending money is going to be taken up with dialysis payments. When you have a transplant, now once it's safe for you to travel, you don't have to look at anything like that. All you have to make sure you have your enough medication for the time that you're there. Obviously, you continue those little precautions that you would normally take, but we don't allow you to travel within the first year because your doses are generally still high, and you're still at risk for infection. So we like to keep you close to home, just to monitor you. But after the first year, you're free to travel.
Yeah, it's all, and you, as you said, you have a critical role in the monitoring of that patient as they try to get back to some level of normalcy in their life, and even normalcy coming off of dialysis, because they would be accustomed coming to the hospital, as you said, 3 or how many other times a week, and now they can spend the time focusing on a healthier lifestyle. Talk a bit about that conversation that you have as well, Dr. O'Shea. Is there more light at the end of the tunnel as we try to promote coming off of dialysis and moving to transplantation?
Well, I would say the more we do, we've done 16 since 2015, and 100% donor survival.
100% donor survival.
Yes. Or we have lost a few patients, sadly, for reasons associated with transplant, some not associated, but the kidney was functioning. One patient we have lost the graft. I think as Rufus pointed out, there's still a lot of care with the fluid intake to make sure you preserve that kidney, and also 1 or 2 of the food she mentioned. But for the most part, patients are down to maybe 1, 2 immunosuppressive drugs about a year or 2 out. But still, care has to be in, once you're having a lot of fluid losses like diarrhea or whatever, vomiting from, if unfortunately get gastro, you still have to keep on top of your medications and still keep on top of the drinking. So unfortunately, we did lose one patient's graft, which is the new kidney, and we have lost one patient's, one with malignancy and one with a heart issue. Because the recipients after being on dialysis for a long time, one of the big things that affects is the heart, and patients do end up having, heart attacks. And of course, then if you have the catheter in for the dialysis, you can get infection. And so it's difficult on the body, the dialysis, because it's an artificial situation, so it does affect the patients. And the longer you're on dialysis, and the more problems you have, even then when you come to transplant. So we have to do a lot of vetting for our transplant patients to make sure that they're fit for the operation and it's successful. But sometimes, with any operation, nothing is 100% guaranteed. So that has explained to the patient too coming into it. But certainly, the transplant in terms of quality of life and length of life is more beneficial, and this is what we emphasize to the patients. And a lot of them, if we were to generate a waiting list of people who would like to get a kidney, that would be long, but then it is the donors that we're falling down in terms of living. At some point we would like a deceased donor program, as you mentioned, Dr. Greenidge mentioned as well, which would a big undertaking for a hospital, but we have had oversee international assessment of our hospital, and it is a hospital of the high standard and we could have a deceased donor program. So it would just be to get the appropriate legislation. Right now we don't have that. So I think it is in Parliament to be debated, so that has to be approved, and then we would need to do the public awareness, and then we're doing it now, public awareness, so people can have that conversation to what they would want to happen to them if unfortunately they die suddenly. What would you want to happen? Would you want your body to go into the ground, or would you want to save somebody else's life instead of being buried?
And this month is Kidney Month as well.
This is Kidney Month, and when you were talking about life after transplant, we have a patient who went on to have a baby, a beautiful girl, and she's going to be on Morning Barbados later this month, celebrating Kidney Month. So
one of our big successes.
That was a beautiful little girl. So we this is something that is such a feel good feel-good procedure, in terms of giving that person a life off of dialysis. And we want to do more. We want to do more of it, provided we get patients coming forward, donors coming forward.
And in terms of nursery, I think it would be good if you, because you deal with the patients, many of them one-on-one, helping them to understand what has to happen. Education on the cards from your side in terms of nursing?
That's always been one of my plans, but it's never really
materialized.
Materialized.
We gotta turn it into some action.
It's something that I really would like to do, to let our, you need to have, in order to have a successful program, first of all, you need to have buy-in by persons within the organization. And you can't have that unless you have education, because after how many years, about almost 30 years of having transplants around the hospital, a lot of persons still don't know that we do transplants. Like something. So if we can get that kind of education out there, I guess we get greater buy-in. Because as the service expands, we are going to need more staff, and you're going to need to train persons in, not only like myself as transplant coordinators, but you're also going to need nursing staff. Nurses who are trained to work with these patients.
And that's where we need your expertise, because we are getting the staff. We've seen a number of nurses come on board over the last few months, and as a part of the new strategy, which you would have heard right here, listeners, on the Pulse Radio Show in Season 2, we're getting more staff across the board. So definitely some more coming in your region, but as you said, that's where your passion will come in terms of training these people to work with your team so that we can get to Dr. O'Shea's target. So let's talk about your targets, Dr. O'Shea, as your overall vision for transplant surgery in Barbados. Of course, hopefully we get more Barbadians in that mindset to understand that they can help to save a relative life. I don't, will we get to that, or is it possible to get to that point where we can see donors outside of a relative? Because I think in most cases it is a relative that will donate.
We either a relative or a friend. I mean, like I mentioned, the crucial thing is the blood group, and then we do for the tissue typing. But yeah, other countries that have what they call altruistic donors. You put an ad on Facebook and somebody pops up and said, I want to give a kidney. Wow. Of course, we have to vet those patients psychologically. But there are those people out there who see a need and are willing to go through with the surgery. And it's common in the UK and other places. So there is that. And we would like to get, the current infrastructure and budget, if we could do, 10 living a year, if we could get to deceased donation, maybe 20. But we have to work within the current infrastructure and the current budget that is allotted. So, of course, fit is not the only thing that the hospital is treating, so we are mindful of that. But we would like, and we think once we have more positive outcomes, and as Bruce was saying, people don't even know, more people know, more people will come forward. And of course, people like to see good outcomes to make them feel reassured, and we do more PR. So that would be a significant dent in the current budget that is allotted to dialysis, which is now about 12% in the hospital budget. So that is where we can actually save money and then reinvest it then into marketing for more people to come forward.
And maybe you can
maybe to the region as well.
Give some clarity on that. The expense for donation, and then probably the add-ons, which would be medication after having the kidney, compared to years and years on dialysis. If you could give that. I remember you doing a comparison last time we spoke.
Yes, well, with the upfront costs, which for us would be about the first year, say about $50,000 US in terms of the work going into getting the patients through the transplant, but that can drop down to about $20,000, which compared to dialysis, which is about $60,000-$70,000. Not including dialysis itself, but sometimes people come in with infections.
And this is $60,000-$70,000
Barbados dollars
on an annual basis.
Annual basis, yes. So, you can see the savings a year of about, 30, $40,000 per patient. So, take that forward to increasing numbers, and that then can be put back into dialysis. And then these patients also then free to go back to work, free to have children. And I know there's a big push. We keep hearing we need to have more babies to increase the number in our country. So it's just putting people back into a more active and functional and productive life. So I think that has a win-win on many levels, aside not just from coming off of dialysis.
Well, you'll see Dr. O'Shea next week on Morning Barbados, so you can look out for that as we celebrate Kidney Month and raise awareness during this month. And Nurse Shori, I'm pretty sure you'll see her coming back to the show as we have more of these conversations.
Education.
Yeah, she's looking at me. No, I don't mind how you look at me. She, Dr. Ruth, registered nurse Shori, she's going to come back and spend some time with us because the education is important. We thank you for spending time with us here on the Pulse Radio Show, listening as we spoke about kidney transplants, the new lease on life. I'm Shane Seeley on behalf of Dr. Margaret O'Shea and registered nurse Ruth Shori. I'll see you next time with more information coming from the Queen Elizabeth Hospital right here on the Pulse Radio Show, sponsored by MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.